morning. Good morning. Can everybody hear me okay? No? Is that better? Yes? Yes. Good. All right, so we're going to continue to talk about injectable anesthetic drugs this morning. First off, I want to ask you if anybody has any questions from anything we talked about Tuesday. Do you have any questions about your exams? What is that, tomorrow? Anything that doesn't make sense to you that was covered by Dr. Bednarski or Dr. Lurch? Anything that doesn't make sense from Tuesday's lecture? Yes? Yes. I think it depends on what you want. So you're right, atropine crosses the blood-brain or the placental barrier, glycopyrrolate does not. So if your goal is that you want to increase the heart rate of the fetus, then you would use atropine. Yep. Any other questions? All right, so we're going to continue talking about the injectable anesthetics, and in your notes there may have been something that was written a little bit wrong. For whatever reason, methotrexate used to be up underneath etomidate. That is not correct. Methotrexate is a barbiturate. So this slide is correct in case you saw it anywhere differently in the rest of your notes. So we're going to start off by talking about etomidate. Etomidate is an imidazole derivative, and it's solubilized in 35% propylene glycol. Does anybody know any other drug that is present solubilized in propylene glycol? Diazepam. Yep. So why is that important to us? It stings. It stings a lot, right? It's supplied as a single isomer, so this is different than what we talked about with ketamine. It only has one, whereas ketamine is a racemic mixture. And etomidate is classified as a hypnotic. It penetrates the brain rapidly, so you get peak concentrations within 1 minute of injecting it into a vessel. Induction is rapid, but it can be rough. Recovery is typically rapid and smooth, and the way that you can make your induction smooth is to make sure that you pre-medicate your patient. Duration is about 5 to 10 minutes after a single injection. The duration of action is dependent on rapid redistribution, and this drug is metabolized in the liver. When in doubt, liver. Etomidate is used clinically as an anesthetic induction drug, so just like you would use propofol or ketamine midazolam or xylazole, because it has that rapid onset and rapid recovery. And even in patients that have organ system dysfunction, you will redistribute it and you'll metabolize it over time. So your patients will wake up even if they don't have a really functional liver, but it'll take them a while to get rid of the drug out of their body. You can use it to provide long-term restraint, but this is not recommended in most patients with etomidate. So it's possible to do, but I'd probably pick something different. And we're going to talk about why here in a second when we go on to the other effects. The CNS effects, just like we talked about with propofol, etomidate works on GABA receptors. So when you think GABA receptors, think etomidate, think propofol. It causes minimal respiratory depression. It's one of the reasons we like it. You can give it and your patients are still going to be breathing. Very different than what we experience when we give propofol to our patients. It can cause a decrease in your tidal volume, which may result in an increase in respiratory rate, but usually their end tidal CO2 is going to stay about the same. This is the number one reason that people use etomidate. The cardiovascular effects are minimal. So people sort of think of etomidate as being heart-friendly, cardioprotective in a way. Minimal changes in cardiac output, minimal changes in blood pressure, minimal changes in heart rate. But some of the other effects are the reasons why some people don't like etomidate. You can get pain or discomfort on injection. Part of that is probably related to the propylene glycol. The other part is that this is a hyperosmolar solution, so that can also cause pain. You can get myoclonus or retching. Sometimes this is really ugly. So you saw that video of myoclonus Tuesday when we talked about propofol. It can be really, really dramatic with etomidate. At the retching, you get half of your dose in, and it looks like your patients are going to start vomiting right there on you. It's really gross. You can get by most of these things if you pre-medicate your patients. So with appropriate pre-meds, you're probably not going to see most of this. The most significant side effect that we worry about in some patients, really, really sick patients, is that it can cause adrenal cortical suppression. So effectively, in a way, you're going to make your patient an Addisonian for a short amount of time. So is this a big deal? Well, what if you already have an Addisonian patient? Good idea, bad idea? I don't think anybody really knows. If you have a really sick patient, so this comes up a lot in pediatric medicine. You have really, really sick babies, you give them etomidate, you suppress their adrenocortical system, they tend to do really, really poorly. So it's a giant battle between their anesthesia service, the criticalist, and the intensivist over in the human hospital about whether something gets etomidate prior to intubation. Some people say, yes, it's the best thing, it's cardioprotective. Other people say, yeah, but now I'm going to have to deal with this patient who's effectively an Addisonian for 2 days. Usually this adrenal suppression is short-lived, 4 to 8 hours maybe. So in most patients, probably not a big deal. But the long-term CRI, this is why it's not really recommended. I wouldn't pick this for a long-term CRI. Now, any questions about etomidate? So now we're going to talk about the barbiturates. Barbiturates are any drug that's derived from barbituric acid. There's a nice list over there on the left-hand side. We don't use these widely in medicine or veterinary medicine anymore for a couple of different reasons. Number one, barbiturates are controlled drugs. So it's one more thing you're going to have to keep track of. There are newer, potentially safer drugs out there on the market. Propofol, when used in good hands, might be a little bit safer. Some of these drugs are really expensive. So if you wanted to choose methotrexate, for example, it's cost prohibitive to do that. So you've got to have a pretty good reason for choosing that drug over something else that's less expensive. And some of these drugs are no longer available in the United States. So does anybody know why thiopental is no longer available here? Back in 2011, Hospira, who is a maker of thiopental, had some manufacturing issues here in the U.S. They decided that instead they were going to manufacture it at their plant in Italy. Well, the Italian government said, no, no, you're not going to be able to do that because thiopental is used in the United States for execution. Italy has a problem with that, and so they actually wanted Hospira to say there is no way that thiopental is going to make it into a situation where it can be used for an execution. And Hospira said, I can't guarantee that that's going to happen, so they stopped making thiopental. It's not available for our use, it's not available for the use in human medicine. We just don't have it available because they use it for execution. Why do you need to know it then? Well, because barbiturates are still going to appear on napkins. You're going to need to know about the barbiturates. And the availability of drugs do change. So what we have today isn't necessarily what we're going to have tomorrow, or it's not going to be the same as what we had a year ago either. So some of the important things to know about the barbiturates is that carbon atoms 2 and 5 are going to be really important. And these are numbered up here. Let's see if I can make this work. So carbon 2 and carbon 5. Substitutions at these carbon atoms change the effects of these drugs. So you're going to get more hypnotic potential with certain things. You're going to get more seizure control with other things. Carbon 2 is going to be important when it comes to classification of these drugs. The other important thing to note is that the sedative effects and the anticonvulsant effects are separate. You use them in different ways. So to begin with, barbiturates with an oxygen atom at C2 are classified as oxybarbiturates. Those with a shorter duration if you've got that sulfur atom rather than an oxygen atom. If you have a phenol group on carbon 5, you will get more of an anticonvulsant property for your drug. It's one of the reasons we use phenobarbital for the treatment of seizures. And barbiturates with branch chain substitution on C5 have greater hypnotic activity, like methotrexate. So we don't usually use phenobarbital for induction of anesthesia because it doesn't really get us the hypnotic aspects that we actually want. So I think that's going to be it for your chemistry lesson for today. But again, like we talked about with propofol and etomidate, the barbiturates work on GABA receptors. So that makes 3, right? 3 drugs that work on GABA receptors? The onset and duration of barbiturates are proportional to their lipid solubility. So the anesthetic effect and duration is related to the drug redistribution from the brain. So you give this drug, it hits the brain, you have an effect, it goes out of your brain into your fat, and it gets redistributed, and that's what makes your patients wake up. The redistribution is related to ionized state of the drug and plasma protein binding. And they're metabolized depending on their classification. So oxybarbiturates are metabolized only in the hepatocytes of your liver, whereas the thiobarbiturates are metabolized by the liver, but also broken down in the kidneys and even in the CNS. So you're going to get rid of these drugs in different ways depending on what type they are. So pentobarbital, used as a general anesthetic in laboratory species, rats, mice, can be used to treat refractory seizures, and it's the most common, it's the primary component in euthanasia solution. Dr. Hubble is actually going to teach your lectures on euthanasia. He's going to probably talk about this briefly. Usually, depending on what type of euthanasia solution, sometimes it's just pentobarbital, sometimes it's pentobarbital in combination with other things. So phenytoin is probably the most common. And whether there's phenytoin present or not present will alter the schedule of the drug. So if it's alone, it's a DEA Schedule 2. If it's included with phenytoin, it's Schedule 3. Historically used as a general anesthetic, we don't really use it anymore. If you're going to go into research, then this might be something you're going to come into contact with. But since you guys already told me that you don't love anesthesia and you don't want to be anesthesiologists, I'm going to guess you don't want to do anesthesia research either, so you're probably not going to use this very much except for euthanasia. Cardiovascular effects of pentobarbital, you get decreases in heart rate, decreases in cardiac output, your blood pressure decreases, all the things that you'd sort of expect from a euthanasia agent, right? Thiopental is probably the barbiturate that we used the most. It's going to be the one that's most likely to be asked about on your board exam. It is Schedule 3. It comes as a powder and it has to be reconstituted. Used clinically for anesthetic induction, lasts about 10 to 15 minutes, recovery in 30 to 45 minutes. The rapid onset is the reason we like this drug the most. So we used to do equine anesthesia, and we always had something hooked up to the line in case the horse moved, right? So if you've got a horse in Joseph redundancy, you're in a surgery suite, if that horse starts moving, what happens if it comes off the table? Probably not a good thing, right? Surgeons tend to frown on that a little bit. Well, the interesting thing is that if it comes off the table in the room, not only do you have to get it back to sleep, then you got to drag the horse out and re-hoist it up onto the table and hope it didn't take out your equipment or your personnel in the meantime. So we always had thiopental hooked up to the line because it acted so rapidly you could give an injection and that horse would stay on the table. We now have ketamine attached to the line, which does its job, but it takes a little bit longer, like we saw on Tuesday. The respiratory effect, it causes respiratory depression, usually apnea, short-lived, but it definitely happens. And people report laryngospasm and hiccups when they get this drug. The cardiovascular effects are actually going to be really important. It causes direct myocardial depression, so you get decreases in cardiac output, blood pressure, sometimes you get an increase in heart rate. and it predisposes your patients to a ventricular arrhythmia. So does anybody know which arrhythmia we're talking about? What is that? So you have VPC, normal, VPC, normal, VPC. Bigeminy. Yep. Really, really common. It can even happen in animals that have no underlying cardiac disease. Animals with no murmur, no conduction disease at all can get this as an effect of thiopental. So we had a dog that came in for a TPLO, normal, mixed-breed dog, no cardiac problems that we knew of, pre-medicated with ace-prompamine, gave thiopental for induction, and this is what happened before we even got in the room. So what do you do now? How do you treat this? You could try lidocaine, yep? So you give a dose of lidocaine and it gets back to normal. And how long do you think that lasts for? Yeah, not very long, so a couple of minutes and then it went right back to this. So now what do? More lidocaine? You can try that. What else can you do? Tell the surgeon you're not doing surgery today? Yeah, so we woke this dog up. So the dog's awake and it's still doing this, and it's in ICU and it's still doing this. And it had a cardio consult while it was still doing this. And about 6 hours later, it went back to a normal sinus rhythm, like nothing had happened. And it came in for a reevaluation of its heart, no problems, no conduction disease, no issues. So about a week after that, it came back in for a retry on its TPLO. So what do you think about giving a thiopental again? No. I was actually really hoping I wasn't on service that day. Unfortunately, I was. But it worked out great because the dog did fine. We did the same pre-medication, but we induced the propofol, and this did not happen. You can reduce the incidence of this arrhythmia if you pre-medicate your patient. This is what, yeah.
So, that's very specific.
Sometimes that can be helpful. So Dr. Bednarski told you that ace-prompamine has an antiarrhythmic effect, and it does. Sometimes ace-prompamine isn't going to be strong enough to help with something like that. And so ace-prompamine is actually really, really helpful for catecholamine-induced arrhythmias, not necessarily due to other reasons. And so if you have a patient that already has an arrhythmia, I would probably, and I thought ace-prompamine was great for other reasons, I'd pick that and hope that it helps me. Yep. But it doesn't always keep that from happening, unfortunately. Thiopental causes splenic engorgement and a decrease in your PCV. And if you get it outside of a vessel, this is what can happen to your patient. So you can slough skin right off. It's pretty gross. It's contraindicated in sighthounds. Does anybody know why? Prolonged action? All right, so what happens when you give thiopental to a sighthound is that the drug has to be redistributed too fast. And so if you have a greyhound, how much fat do they have? Not very much. And so it's going to take a long time for your patient to wake up because this drug doesn't have anywhere to go. As a secondary effect, most sighthounds, especially greyhounds, have issues of hepatic metabolism. And so not only do they not have any fat for it to go to, but now your liver is not working so great either. And so it's one of those weird things about sighthounds, greyhounds. We love them, but we also don't love them. I think the biggest thing to remember is that it's probably not going to kill your patient, right? They're just going to sleep for a really, really long time. And so if I was going to say that there was an absolute no-no, I would say this is it, but it probably isn't going to result in the death of your patient. If they ask you on boards about thiopental and a breed of dogs, greyhound. No problem. We're going to talk really briefly about methotrexate. It's an ultra-short-acting oxybarbiturate. It's really expensive right now. It has similar effects to thiopental. You can use this in sighthounds. So this isn't going to have the same lipid solubility issues that you have with thiopental, so you can give methotrexate to a greyhound if you want to. You can get convulsions, myotonus, and rough inductions. Again, you can limit that a little bit if you pre-med your patients. So here's a sample question for you guys for your exam, not tomorrow, but later. What would you expect to happen with blood pressure and respiratory rate following propofol administration? You can talk amongst yourselves if you want. All right, what do you guys think? Somebody have an answer for me? The last one? Does everybody, who agrees? Does anybody disagree? Yes, the last one. So blood pressure decreases, respiratory rate decreases. You get hypotension, and most of the time you get an affectation. Any questions about this? Do you have any questions about the drugs we've covered so far? Okay. Here's another question for you. Alright, you guys have enough time? Anybody have an answer? Ketamine. Everybody agree with that? Does anybody disagree? Yep, it's ketamine. So, are you not disagreeing, or are you just looking at the feeling? Were you disagreeing, or were you staring at the feeling? Okay. Just want to make sure. All right. So some of your questions on your exam covering the induction drugs are going to be more simple, like this. Here's the next one for you to decide. So I'm going to give you a couple minutes. You can talk to your neighbors, decide for yourself which you would pick. All right, you guys ready? So what would you choose for anesthetic induction for a young, healthy dog that's having a TPLO? How many people would pick propofol? All right, somebody tell me why.
The food induction, the good recovery, the quick recovery, the kind of
Okay. How many people pick ketamine and midazolam? Yep, how come?
Ketamine is a good analgesic, and it's going to be a mess.
Okay. Yep. Anybody pick thiopental? She said because of pain, TPLO procedure can be somewhat painful, and so since ketamine does provide some analgesia, she decided to pick that. Who picked thiopental? How come? Yep. Yep, good reason. How many people would pick etomidate? Nobody? In actuality, you could pick any of these. You have a young, healthy patient. You could give this drug anything you want and it would be fine. So propofol is an absolutely appropriate drug for anesthetic induction. You would have pre-medded your patient. Yes.
Sorry, would that when the young patient comes to this area?
So you could consider that about pre-medication. So if you use midazolam as a pre-medicament, you can get a patient who can become excited. But when you administer it as a bolus in a syringe with ketamine, you're not going to see that. You'll see a tiny little excitement phase in almost any patient, but usually they're going to have a pretty good, nice, smooth induction. It might take a little bit longer to get them intubated, but that's okay. Yeah. Good question. So propofol would be appropriate. You've got a patient that's been pre-medicated with a sedative and an opioid. You use this for induction. You're going to place your patient on a maintenance drug, usually an inhalant. And Dr. Dykes is a pretty fast surgeon, so you're going to be in surgery for about an hour. And so propofol probably would be long gone. But so would ketamine midazolam, right? And ketamine is a good choice. It is going to provide some analgesia, but you're also going to do something else. You're going to pick an opioid for your patient too. So you can make a case for doing ketamine in that fashion, but you could also do ketamine as a CRI if you wanted to have that on during your procedure. Would also help with pain. Yep. Thiopental would be appropriate in a young, healthy patient, absolutely, if you have it available. And etomidate actually would be appropriate too. You don't have to use etomidate. You're not worried about this dog's heart. It wouldn't be wrong to do it. You're going to get a good effect if you've pre-medded your patient, hopefully a smooth induction, and you're probably not going to notice much difference between an etomidate induction and a propofol induction in a pre-medicated patient. So any of these would be appropriate for a young, healthy dog. What about in this cat? Is there anything you wouldn't want to pick? You have a mass removal on an aggressive cat that has a 3 out of 6 murmur, that has HCM. Is there any of these that you would choose or any that you wouldn't? So you guys can talk. I'll give you a couple minutes. How about atominate? Yeah, I'd probably take atominate in this cat. Propofol you could choose, but the one bad thing about propofol in a cat like this would be that you're going to make the heart speed up a little bit. And with HCM and HOCM, you definitely don't want the rate to go much higher. You sort of want to maintain an even keel, right? Keep things exactly as they have been, and atominate is probably going to be the best choice for that. Yeah?
Didn't you talk about propofol being toxic?
It can be, so it can cause a hind body anemia, but that doesn't mean you can't give it to a cat. And so we talked about the fact that cats are more susceptible to that. But if I thought propofol was appropriate for this patient, one dose isn't going to do it. Yeah. Good question. So they actually did a study where they took cats that were having radiation therapy, and they were having radiation therapy every day for like a month, Monday through Friday. And they gave them propofol 5 days a week for their radiation treatment. And what they found is that some cats did develop Heinz bodies, but they didn't seem to be clinically significant to the cat. So I think you could still give propofol to the cat.
So, I mean, doing like a propofol CRI for like 12 hours would still...
It could be, yes. If you thought it was appropriate for other reasons, I would consider doing it in a cat. Any other questions? All right, so the last two things we're going to talk about are two different drugs. One is MS-222, and the other is alfaxolone. MS-222 is the fish anesthetic. It's a powder that you put in water, mobilizes fish. It's the only anesthetic that's FDA approved for food fish. There's a 21-day withdrawal period, so if you have to anesthetize a fish today, you got to wait 21 days before you can eat it. It is a benzocaine derivative, and it is acidic, so a lot of times you have to buffer the water. And so you put it in water, and then you usually have to add some sodium bicarb. It's typically used for light anesthesia. It can be used for surgical anesthesia. And you can use it for euthanasia. This is actually Dr. Lisa Posner at North Carolina State. They're using a recirculating system and monitoring these fish for different diagnostic procedures. Sedation is characterized by a decreased reaction and a loss of opercular activity. You can get deep anesthesia, and basically you can wake these fish up by putting them in water without MS-222. So there is a link up here. Fahim Noor and Dr. Richmond Lowe at Murdoch University actually made this video for you. So if you have the opportunity, I would check it out. You can actually watch them put salt, they put MS-222, and they put bicarb in the water, and then they anesthetize the goldfish and wake it back again. So this link obviously can be, I can put it on Carmen for you so that you can access that at a later time. There are some alternatives for fish anesthesia, but these are not FDA approved for food fish. If you're going to anesthetize a koi or a goldfish that you're not planning on eating, these would be some good options for you. Clove oil, isoeugenol, CO2, so basically Alka-Seltzer in the water. Inhalants like isoflurane you can pour into water, and then metomidate and lidocaine are also options. So some good alternatives, and we don't do a lot of fish anesthesia here, but there is a fourth-year student, Stephen Reichley, who's actually doing aquaculture, and he actually arranged for Dr. Lowe to make these videos for you. The last thing we're going to talk about is a drug called alfaxolone. It's a neuroactive steroid that's not currently available in the U.S., but we're getting some indications that it should be approved either by the end of this year or into next year. And so this could be something that you will come into contact with next year when you get to fourth-year clinics. It's available in all the UK countries, so Canada, the UK, Australia, and New Zealand. Even if you went to St. Kitts, you'd be using alfaxolone. But unfortunately, it's not approved for use in the U.S. You can use it in dogs and cats. You can administer it IM or IV. Induction is rapid and smooth. And I have a video of what an alfaxolone induction looks like. So this video was actually taken at the University of Prince Edward Island, where they have alfaxolone available every day. And they administer it typically slowly, the same way that you would for propofol. This is a 1-year-old lab. His name is Mayo. It's very cute. Still blinking. And that's just flush for the catheter. So how different did that look to you from a propofol induction? Maybe a little faster? Anybody else? Look pretty much the same? So really the biggest thing about induction drugs is that for premedicated patients that are young and healthy, inductions are going to look pretty much the same. Alfaxolone, as an added bonus for you, it works on GABA receptors. The respiratory effects are minimal, especially at lower doses than if you go slow. You can get some apnea if you give it at a high dose, and if you give it rapidly, a lot like propofol. Cardiovascular effects are minimal at lower doses, but at higher doses, you can see some of the similar effects of propofol, some hypotension, maybe an increase in heart rate, and you do get some good muscle relaxation. I put this up here because it might be a good thing for you guys when you are trying to study for your exam to make a table similar to this. How do these drugs work? What are the cardiovascular effects? What are the respiratory effects? What are some of the other effects that we should know about? And how are they metabolized? And that might help you to keep these drugs straight. There's a lot of information and a lot of different drugs that you need to know. And this might be a good way that will help you. Are there any other questions that I can answer for you? Steven?
How long did the alfaxolone?
You'll probably get about a good 20 minutes from a single injectable dose if you give it IV. Yeah.